Hey guys, my name is Mark Rouse. And most people, when they look at my last name, it looks like Rowe. I just tell them if you can get Mark right, I'm fine. We're fine there. I also walk around a lot, so does anybody have any ICU experience? Preferably neuro, probably by the time I get off of here. But what we're going to talk a little bit about is my journey at the University of Arkansas, which was the medical center that I worked for at the time. I'm now retired. It's just that I don't go to work every day after 40 years. So we're going to talk a little bit about our experience with vascular access. So our talk today, I'm going to talk a little bit about our experience and the actual research articles and stuff that we have presented and were printed in 2020. Tell you a little bit of our backstory too. Anybody feel like this on a regular basis? It's the same circle. I solve one problem, another one creates it from it. You make another one, and you keep going around. We did that a while back, and we were having trouble with our central lines. And the trouble seemed to happen on the day that we were doing dressing changes. We did protocols that they pulled out, they jumped in, all those kinds of things. And we were like, okay, so what's going on? So we drilled down on it a little bit. And I'm one of those people that sometimes do things deceptively. So I'm a vascular access specialist. So I placed the lines. And so at that time we were using an adhesive device. And the nice little pads on the adhesive device hold well to a surgical marker. So I'd make a little tick on the marker with the marker on the actual adhesive. So I'd go back on the next dressing change and say, oh, they changed the bandage. And I'd still see my little tick. So I know that they changed the adhesive device. So we drilled down. I said, safe zone, went to the nurse, said, let's talk about this. What was the reason that this wasn't changed? And you do know it has to be changed with each dressing change. Yeah. We're scared it's going to move. We're scared you're going to scream at us. No, not really, but, just that movement, that micro-pissoning, which is what's a big issue related to it. So we said, okay, let's drill down. What are our options? So right now, we're just going to kind of go through the options that we have. So we were looking at transdermal devices, such as sutures. Sometimes staples are even used. Mainly for your CVCs, your IJs, your subclavians. I call it down in the basement too, down in our femoral zones and stuff. Many times we use sutures. It's there. Then we also have our cutaneous. These are things that are attached to the skin in some way. Many different brands. I've got some listed there for you. So these usually have adhesive properties, which we all know in nice, hot, humid environments and stuff. We also have trouble with things sticking to the skin. And I'm preaching to the choir. I know shedding of skin also happens. So in about a 4 to 7 day period, you're just getting to shed that skin level, and anything stuck to it is also going to shed also. So we're working with that. Also, in the cutaneous, because it's applied to the skin, everybody's heard of the glues that are out there. Different types of glue, one in particular, it's great advertising and stuff here also. So that is a cutaneous because it is on the skin level itself. And the last one that we looked at whenever we were trying to make a change to solve the problem was the subcutaneous. So basically through the skin and into the subcutaneous tissue, a type of securement related to that. So we went through all three different types and said, let's talk about the problems, both positive and negatives with each. So sutures, I won't ask for hands, but people are still sewing things in, right? We know that sutures, if you read the IFU for sutures, never does. So I'll tell you, it says use for wound closure. It was never intended to be used as a securement device. So who has the suture or the providers that put in stitches that are so tight, they're pulling through the skin and dimpling and you can't clean under them? Or who has the ones that are so shallow and have so much movement that the catheter's moving in and out with the movement of the patient and stuff too? Also, the majority of providers were using silk for years, still are. Silk is a great infection source because it's usually 3 or 4 braids wrapped with a single wrapping of another silk. So it has crevices in the wrapping. Great place to hold bacteria, right? So my motto is ditch the stitch. Don't like stitches, definitely. Also, when you look at the breakdown of it, increased infection risk. You're putting 2 extra holes right next to the line hole that your catheter is going into. So many times your suture becomes angry, hot, just right on the infection zone there. And it goes straight down the zip slide, right next to the hole. So many times you'll have the suture that gets infected first before the central line does. Also looking at the cost of a needle stick injury. I don't have to preach to the choir here. If you have a needle and it's on your field, the potential exists that you're going to have a needle stick injury involved with it. Okay. Also looking at just ability to clean. We talked about the inability many times with suturing to get things under to clean correctly. Right. Also the erosion of the skin itself. Different suturing techniques. Many of our providers are taught different techniques. Sometimes they're interesting. Sometimes they're wrapping around things you have no idea how they got there. I've actually seen an IJ wrapped around the ear and sewn to the cheek.
Oh.
Not pretty, no. Also, the placement of a suture also has cost involved with it. So when we're talking about minutes in the OR, we're talking about $20 to $60 per minute. That's the charge for placing it. So if we can avoid a suture, we can also do some healthcare costs and stuff there. There's a learning curve related to them, and it violates, needless to say, the needle stick laws and stuff related to needle and the use of non-needle devices. So when we talk about adhesives, adhesives have to be stuck to the skin. We talked about the shedding of the skin and the fact that those adhesives will lose their property because of the shedding itself. So anything on the skin will lose its adhesive property. They also have to be replaced with each dressing. We talked about that. We know that they're not always replaced with each dressing. So they're a vector for infections just because they are right there next to the site. You put a nice new dressing on it, it doesn't mean that that isn't a vector right under your bandage. Also, during the dressing change, we talked about the movement of catheters, right? In and out. So it goes both ways. It's secured right next to the skin, right next to the site itself. Also, the motion is an increased risk of infection related to that. Also, anyone seeing adhesive-related skin injuries, MRSI, CRSI, all related sometimes to the adhesives that we're placing on our patients. Decreasing adhesive may be decreasing a lot of our issues. Also don't work well with compromised skin, diaphoretic skin, and adhesive's not going to work as well. Also looking at foreskin integrity. I'm also affiliated at the time with the Cancer Institute, so we had a lot of graft versus host. We had a lot of burns. They didn't have skin to be able to attach an adhesive to. So we looked at other things. So we went through the possibilities, okay, that's not a good choice for us. So we also, at the time, even though it came out after, now some of the properties of the glue itself. The glue is a great device. I use it on some catheters for specific reasons. It's not put it on everything kind of thing. It's one of those, the reason that it needs to be there, you need to place it for those reasons. It has not been proven as a securement for especially central lines. Okay, so we're talking IJs, we're talking femorals, we're talking PICC lines as a securement itself. Like adhesive, the glue has to be removed with each dressing change and reapplied due to the shedding of skin. The big thing is the removal, which everyone needs to really, if you're using glue, again, love the product if used appropriately, but people need to remove it completely before reapplying it with each dressing change. Also, the IFU states the reapplication has not been evaluated for long-term securement. I'm one of these people that say, anytime I put in a central line, I'm considering it long-term securement because it needs to be there as long as the therapy needs to be there. That may be 2 days, that may be 2 weeks, 2 months, 2 years. I'm planning for everything to be long-term, and hopefully it comes out sooner. Okay. Also, there's an Australian study that's out that talks about tissue adhesive showing a 17% dislodgement with a median draw of 63 hours related to using it as a securement device. So, has its properties, but not always. Barbara Rudy, a good friend of the vascular world, is a big researcher out of Italy. He basically came out and said, I like it for peripheral IVs, I like it for midlines, everything else he didn't think it had a place. Still uses it for specific reasons, but not in its securement capacity. Okay. So now we're getting to the study. I hate to toot my own horn, but myself and two other colleagues, Dr. Kevin Arnold is a statistician and a nurse vascular access professional, and Tim Spencer is out of Arizona, who was one of my co-writers and stuff with me. I was the lead. It came out in 2020. And what we really wanted to focus on, because I'm going to go through a lot of the studies, this is in 2020, during that pandemic kind of thing, and just before, so a lot of things kind of shut down. So I want to review this, but then I'm going to give you some more up-to-date data and stuff also. What we wanted to know from my data from the University of Arkansas was, what about CLABSI? Everyone's talked about dislodgement, they talked about migration of the catheter, but there were very little studies related to CLABSIs themselves. So we decided, hey, I've got a lot of good data. Let's drill down and see what we have. Right? A lot of people have a lot of data that they're sitting on that they really don't know what to do with. So I encourage you, phone a friend, find somebody who can look at it and interpret it in a different way than you've been watching and looking at it forever. Because there's information in it. There's information that other people have questions about. So what we did was we drilled down for a 4-year period. And in our institution, all PICC lines are placed by 2 teams. One team is our vascular access team that do all of the catheters outside of the IR suite. The other one are our IR providers who transport patients to the IR suite for their placement. So I was looking at 2 groups of patients. So I looked at 7,779 patients related to having a PICC line placed in both places. So when I pulled those out, again, I wanted CLABSIs. So these were patients who were in our institution, in our beds, using our equipment, and had our people taking care of them. So they were never discharged from the hospital. So that was the nice force that kept the fact that they were all under the same policies and procedures. So what we found was, after reviewing those, the interventional radiology folks placed an adhesive device on all of their patients. The vascular access team placed a subcutaneous securement device, the SecureCath, on all of our placements. So we went through every PICC, went through every one of them, realized that there was a correlation, or there was not a correlation to severity of the patient. They equaled out when we did a severity scale, so it wasn't that IR got all the bad sick people with all the drains and all the wounds. We got all the nice walkie-talkies who were going out of the hospital the next day. There was an equal variance between the two. So what we did was, we drilled down then to say which one of those 7,000, almost 8,000 patients got CLABSIs. Did a drill down and stuff on those again. So we basically looked at our institution and looked at those patients who got CLABSIs. So you'll see the breakdown there related to 6,941. The QR code on the previous slide directly takes you to the open access article if you would like it. And I'll back it up if you need to there. The study found a significant difference between the 2 related to the CLABSIs, the potential that they are. Our statistician, Dr. Arnold, did a risk assessment. And what he found was the adhesive securement device, the StatLock, had a 288% increased risk of having a CLABSI versus our subcutaneous SecureCath placed PICC lines. 288% difference between the two as far as risk. So significant, and it's back to what we were thinking, because our hypothesis was it's the movement of the catheter. It's that micropiston. It's the personnel who, it came out 2 centimeters, I cleaned it real good and I shoved it back in. We've all seen that, all right? I've seen them go back in when they came out. So our correlation was, this product is working better for our environment versus the adhesive product. The neat thing is this product does not have to be changed with every dressing change. It never has to be changed. You put it on at the time of insertion, it stays on during the entire life of the patient. or excuse me, the catheter. Flip it. So that can be days, that can be months, that can be years. The longest one for my patient that I placed that had theirs removed was a year and a half. Same catheter, same subcutaneous attachment related to it. I know of patients who've almost had the same one in for 4 years, not one that I placed. So it can be in for long periods of time if needed. Okay? So let's look at some of the other chemical studies. And again, I'm not going to read everything related to this. I'm going to highlight them. This is a new study which is very interesting. It came out of Chattanooga in the UK. It was just accepted for publication in the Journal of Vascular Access. So they looked at 9,257 patients with catheter diagnosis with well over 1 million catheter days. Okay? So what they found was their goal was to find out the patients who could survive and keep one PICC line in for 2 years of therapy. Some of their therapy protocols were calling for catheters to be in that long. So what they were looking at is the migration and dislodgement caused from premature removal of a line, hooks, occurred 12% in the adhesive device and occurred 0.4 in the subcutaneous device. So again, it stayed in. It didn't have to be replaced. And if you work with cancer patients, you know their potential of thrombosis is markedly increased because of their diagnosis. So these are the patients who I don't want to put in 4 PICC lines during their 2-year therapy. I would like one PICC line to stay in and not have to be replaced and do vascular preservation related to them, right? So that's a great study. You'll see it. Scan there if you need it. I can go back to them, and that will also take you to the article. Next study I was just going to highlight on is one that was done by John Bell. It's a colleague of mine who he and a few of his colleagues looked at over 8,000 articles related to vascular access securement. So within the article, it didn't have to be specifically for the securement of the device. It only had to be related to the device and mention securement. So what he did when he looked at over 8,000 of those, he and his colleagues, the median dislodgement and migration rate was 1.76 for the adhesive compared to, to the subcutaneous versus 6.77 to a suture-based system. And then we go up to the adhesive, which was 9.69. So sutures, not good, right? So the adhesive properties of some of the adhesive devices didn't do well in this patient population, but yet the subcutaneous securement did, the secure catheter. Right. His comment in the article was, given the current evidence, it is likely that subcutaneous anchored securement systems will be the future of vascular access, especially central venous catheter securement. So, another one with a colleague, this was in the Journal of Vascular Access in 2021, QR codes there. Basically, they looked at, so there it is, 3 year for 93,000 catheter days. So the overall CLABSI rate was 0.76 per 1,000 catheter days for this was a subcutaneous device. And he related them to thrombosis rate. So with those catheters, he put it at a 1.9% thrombosis rate. So he was correlating the movement of the catheter potentially increasing the chance of thrombosis, right, at the actual level of the catheter being placed. Right. Another article. This is more in the pediatric realm. And it talks about the pediatric patients having tunnel catheters that have to be replaced is very traumatic, both physically, for them mentally, and for their disease diagnosis and stuff. So this was looking at the ability for the subcutaneous device to be used for pediatric patients who are having cuff catheters placed. Instead of the trauma of the cuff catheter having to be removed, and or the potential that the patient had to be placed under a slight sedation and stuff for that to happen, the ability to remove this device quickly and easily and relieve the tunnel catheter without having to remove the cuff of that catheter was very good in the pediatric population. Okay. So these are 4 articles. I'm not going to read each of them. These are all pediatric articles talking about good outcomes related to a subcutaneous device. They're there, they exist, they're all recent. We got 22, 20, and 21 there. So when you're looking at the outcome of when you're looking at our articles, we have over 25 articles related to securement devices with subcutaneous that are peer-reviewed with outcomes. There are over 14,800 patients in those articles. They're like our article that we proved, the IRB study that we did, it showed that the 288% chance of risk of infection related to the securement device being subcutaneous adhesive or higher, 288% higher related to that. We have the dislodgement rate of 0 to 1.6 with the adhesive device, with the subcutaneous device, and we have a dislodgement rate of 7 to 12% with an adhesive device. Cost savings, the money crunchers, they always like to hear that. We can prove that the device can save between $15,000 and $100,000 per year. Also looking at over 6 national medically recognized organizations that have endorsed the product itself. Right? So again, life of the line, you put one in, it stays in for the life of the line. Decreased potential enclampsia rates, decreased line replacement rates because it's staying in, right? And a decreased cost saving. All things that people like to hear. So, quick little video here. What I want you to tell me, catheters have marks on them. In our world, it means something. In your world, just think of it as a mark. But what I want you to see during this dressing change is count out how many times the mark moves. So they're removing the adhesive device, cleaning it, very nice. Skin app, protect that skin. Now we're replacing the device. These are the adhesive devices. So how many did you get? 5. 5 times that little mark on the catheter went in and came back out in the process of the dressing change. Is that my 10-minute notice? Okay. Are you guessing 5? All right. So now let's compare a subcutaneous device with an adhesive device in the same scenario. But we don't have to remove the subcutaneous device because it stays on. Just remove the bandage, clean as appropriate, whatever solutions you're using. Allow it to completely dry. Attach any add-on device that you might be using in your facility. All of them work with it. You can use the disc, you can use the gel, you can use the goo. Everything works with it. So again, it didn't move when we used the subcutaneous. It moved the same video 5 times when we used the adhesive device. So, it can be applied to any catheter or any device from a 3 French to a 12. All we've been talking about so far is vascular devices. Let's also consider the nephrostomy tubes, pediatric chest tubes. It is all approved to be able to place on any device that needs to stay in as long as it fits the sizing parameters. So we're from a 3 French to a 12 French. We talked about those nice cuff lines while they're engrafting. Again, no suture, no needle stick injury. They're small, flexible feet. It's made of a laser-scored surgical-grade nitinol. The same material that all of these people, the providers, when they're placing the device, are placing it internally to the patient with their guide wires and stuff. So it is a surgical-grade nitinol. There are no adhesives needed for securement other than the dressing that has to be applied above it. But there's no securement related to the securement itself. No sutures, so no additional holes, no punctures there. Retains in place for the life of the line. It's there, doesn't need skin, needs subcutaneous tissue, and it eliminates catheter movement and dystony. So we've talked about it, decreasing the risk of enclampsia. Dislodgement we've talked about. We know those rates. Okay? So I'm going to buzz through some of these since we're kind of short there. Also, decreasing the cost of replacing the catheter and maintaining the first one being in, decreases migration, dislodgement, stability and effectiveness, 360-degree cleaning. This is where my home health people love them, because they can truly pick it up, they can clean all the way around, put it back down in the same parking space, and not feel like it's moving in and out during the time, and decrease skin irritation itself. So even for CVCs, IJs, who has the providers that place them and they're up here in the ears, here's all the straight up. I remind them gravity works on patients and these catheters the same way it works on them. Many of those catheters we can point down, but they will just access the vessel a little lower, turn it down toward the chest line. It fits better on the chest itself, the dressing, and you'll have a better dwell. Again, decreased potential for collapsing related to that. And that's an IJ catheter placed pointing towards the shoulder. It could have come all the way down towards the chest line. Okay. So here's a national insertion and removal of device. I'll just talk through it as we put it in. So remember, it's going through the exact same hole that the insertion site went in. The nitinol wire is bent by the device. It goes into the insertion site itself. It goes into the subcu tissue. Remember, we have anesthetic there. So this is time to get it seated right where we want it. The catheter is fit into the grooves, the appropriate size, and then the lid is placed on top of the device itself. It never has to be opened in, except for the removal of the catheter. So it's there. It can be cleaned. Notice how it's being picked up, cleaned 360 degrees. This is related to the removal of the device. The lid is taken off. The two methods, the first method is a fold method, which I personally like. The other method was you're actually cutting the device into two pieces and then just removing each side of it. Personally, again, both are an option. Whatever works better for you and your patient environment is great to work with. So, I'm not going to go through these numbers. Needle sticks cost money. Needle sticks cost lives. So, anything we can do to decrease the potential of the needle stick, we need to consider it strong. Guidelines are out there, all mentioning the subcutaneous securement. Sorry. When you do the Amazon check sheet of which one might I like, whenever you're looking at a coffee maker or whatever, it all works out. Quick on guidelines, INS number 38 says a lot about it. So it's in there. And we see skin like this. This is the adhesive-related injuries that we're seeing. Strange how it almost takes the actual marking of the device that was on this. And then many times you'll see, okay, it's so bad that I'm going to move it over here this time. And this one will be irritated and having to be dealt with, while the next one is maybe setting up for the same irritation that happened, and then you come over to the other side. Decreasing the adhesive is so important. Okay. This was a study with the Gavasil with our Italian representatives. There are 3 different protocols. They basically say it's sliced bread. Everything should have it on it related to anything central. Nancy Moreau, a big vascular component who's probably spoke to this organization before, talks about subcutaneous securement. Anything to keep it in, she endorses it with her statements there for preservation of the vascular preservation. COVID in Italy, terrible. Anesthesia Society there said anything related to COVID and placing things in the IJ with our proning of our patients and stuff, they chose to use the subcutaneous over sutures over an adhesive device for that reason. This is a great slide. I wanted to put it in potentially in case you have providers who talk about, I'm more worried about pneumothorax versus eclampsia. I just put it in. Eclampsies happen after I put it in. I didn't cause eclampsia, right? So when you do the breakdown, I'm not going to read all of these. When you do the breakdown between the pneumothorax side and the eclampsia side, there's a big difference. When you look at mortality, when you look at morbidity, when you look at costs, increased length of stay. Sometimes I think eclampsia is unappreciated by some of the inserting providers versus groups like this who know where those dollars and those days and stuff add up. Tendon study. Another classic study that came out a little later, 2012, basically said every time a dressing comes off outside of the 7-day window, we got problems, right? So the first dressing goes on. Okay, if I have to put on another dressing, increase threefolds. By the time you get to that third dressing before the 7-day, we're up to a 12-fold increased potential of infection related to it. So the goal is put the catheter in, apply every add-on device that you need, and apply a dressing that stays on potentially for your 7-day dwell. Okay? The dressing needs to stay attached. We've all looked at the chart. Everything seems to be clean, dry, and intact, right? And you go into there on the 12th roll of tape that someone has applied to the outside of it, right? My mantra is, if you think you need to add tape, you need to change the bandage, right? So, TIMS proved that the catheters themselves. So just as a quick recap, it lasts for the life of the line, significantly reduces catheter-related infections, dramatically reduces catheter dislodgement and migration, decreases replacement costs related to the catheter having to be replaced, thus saving patients' vasculature. Also improving efficiency. A dressing change can go much quicker and more appropriate with a device that you don't have other adhesives to remove. Eliminate suture related injuries. Also lowers the cost of patient care to